I'd like to thank you, Manos and Manos, for inviting me. It feels like a family meeting to me, so I'm always honored to be a member of such a great, outstanding faculty, I would say. So, partial rotator cuff tear. As we already see in the previous presentation, we learned a lot about the natural history. What we can say, focusing on partial rotator cuff tear, we can say that for sure, when we look at the prevalence of these tears, there is an underestimation because not all partial tears are really symptomatic at the beginning. As the patient getting older, there is a higher probability to have a tear, so even a partial tear. And they are more frequent in the feminine rather than in man. For the location actually we always talk about articular or bursal-sided, but the most common type of lesion are intratendinous lesion for sure. What about the etiology? All this type of tear can be basically, for the articular and the bursal side, can be acute, so traumatic, or sort of degenerative. Intratendinous are almost degenerative, of course, and they can come isolated or in combination with bursal or articular-sided tear. Historically, when we think about articular-sided tear, we expected to find this kind of tear in a young population, like athletes, because they usually come from an internal impingement, so repetitive abrasion and microinstability phenomenon, and usually this tear localizes between the supraspinatus and the infraspinatus interval. When we think about bursal-sided tear, most of the cases they are chronic tear, degenerative tear, so the first stage of a future full thickness tear. So it can be the results of very slow subacromial impingements. In younger patients, they can be acute, so traumatic, with a traumatic mechanism. We already learned everything about tear progression. What I'd like to remark in this slide is that tear progression, tear enlargement is going to happen for sure, I could say, but this type of tear can be stable for a few years, so we have time to think at surgery, I would say. Remember, they have poor healing potential, so it can be stabilized, but it's pretty uncommon to heal spontaneously, I mean. There are different classifications. The most used one are the Hellman one, which actually focus on articular and bursal-sided. This is important because that can give us a sort of direction for treatment. So we know that grade 3, when there is more than 50% of involvement of the tendon, probably there is an indication if the patient is very painful to think at surgery, but in the other case, so less than 50% and less than 25%, for sure, I would say that conservative treatment should be considered mandatory in this case. Similar classification in the Snyder one, so it divides in articular and bursal component, defining the involvement thickness of the tear. Later on, particular specific type of partial tear have been defined, but that doesn't change the treatments. For clinical examination, what's the clinical examination? How can you subset in your clinical practice that probably this patient has a partial tear? Pain, similar to a rotator cuff tear, usually worse at 9. In young population, we already say that. We suspect an internal impingement, and so it's probable that you have a partial articular tear, especially in thrower. Thickness is variable. Compared to a full thickness rotator cuff tear, usually you don't have so much weakness. You have a high level of pain, full range of motion, but not higher weakness when you have a partial rotator cuff tear. A special attention, we already said, in overhead athlete, because it can be combined with internal impingement, microinstability, or glenohumeral internal rotation deficit, and some other lesion. How do you detect a partial rotator cuff tear in your clinics? MRI sometimes, especially if not high field, can be difficult to see this kind of tear. So especially for the articular ones, the arthromagnetic resonance imaging has his highest values. I wouldn't recommend an ultrasound for a partial tear. It can be quite difficult and it can be confused with a calcific tendinopathy. But Let's focus on the treatment now, and what we can say we already anticipated. I would say that first treatment for a partial rotator cuff tear is usually a conservative one. This scoping review just showed that even comparing the results from operative and non-operative management in terms of pain control and functional outcome, there are no difference between the two lines of treatment. So it's not worthy to jump on an operative treatment first. What do we mean when we talk about conservative treatments? Conservative treatment option, of course, rest, activity modification, painkillers, physical therapy has for sure an important role. Sometimes when they are very, very painful, this type of lesion can be associated with an initial stage of frozen shoulder, so capsular stretching is important, as well as strengthening exercise. Injection therapy has a huge role, first for pain control. Different modalities, corticosteroid injection, growth factors, mesenchymal stem cells, and hyaluronic acid. Let's take a look to the most used one. So first, this is a comparison between platelet-rich plasma and corticosteroid injection. And this is a randomized clinical trial, not many patients, 6 months follow-up. What we learned, nothing really exciting. I mean, corticosteroid injection are very, very effective in a short-term follow-up. So at 1 month, for sure, they have a similar reduction, PRP and corticosteroid injection. Then the effect of corticosteroid decrease, so probably physical therapy could find a very good spot to solve the issue. But when compared with the platelet-rich plasma, actually it has a long-lasting effect, at least up to 6 months. So when we compare PRP with hyaluronic acid, basically they have the same effect. They can last 3 to 6 months with comparable benefits. But as we know, costs are pretty different. This is a study I would be cautious to be very happy on this study, but at least need to be mentioned because it's a randomized clinical trial. They try to perform an intralesional injection of growth factor of PRP in especially interstitial tears, and they found a sort of healing after 6 months. So you can see the results of the MRI besides a functional improvement. For sure is exciting, it's promising, I would say, but I wouldn't jump at any conclusion after that. And once other promising options are for sure stem cells. Couple of studies are tried the adipose-derived stem cells with promising results. At the end, conservative treatment is for sure the first option. Corticosteroid injection provides a fast pain relief. There are no big difference in pain control and functional outcome when we compare hyaluronic acid and PRP, but for sure there are differences in costs. Future options are interesting, especially if there is the possibility to heal this kind of lesion, especially the degenerative one or the traumatic one, using a sort of biologic augmentation. Thank you. Of course, I will wait for you in May in Milan for the next ESCA and next year for the SIAGASCOT meeting in Napoli. Thank you.